Hello, and welcome to Elevating Outcomes for HER2-expressing GI Cancers peer review session. My name is Josep Tebernero from the Vall d'Hebron University Hospital in Barcelona, and I'm joined by Dr. Subhan Pan from the Anderson Cancer Center based in Houston to discuss the evolving role of molecular targeted agents for both biliary tract cancers and gastric and gastroesophageal junction cancers, and how the recent evidence in reshaping care, including the new data that has been recently presented at the 2023 ESMO Congress. Our goals for today are going to be to learn about the current evidence supporting molecular testing in all GI patients, but in particular patients with BTC and GEA cancers, because this is going to help us to select which patients actually may benefit from HER2-directed therapy. So we are going to be enhancing our understanding on personalized treatment based on molecular findings, also the current evidence that has been presented for those compounds, and specific factors, patient-related factors that we have to take in consideration when treating these patients. And finally, we are going to discuss how to apply practical strategies to manage and mitigate treatment-related adverse events for some of these compounds. I would like to emphasize one important activity led by the Cholangiocarcinoma Foundation, Patients Advocate Foundation, that has set at a web page. You can access to the web page and the data with this QR code, but basically there is tremendous information for professionals, patients, and caregivers. So you will find many actions that you can take in consideration, including but not limited to the International Cholangiocarcinoma Patient Registry, how to find the best specialists, and also how to find and learn about clinical trials, among others. So let's move to the first part of this session, and I'm going to make a rapid review of the critical need for personalized care in GI cancers. First of all, important to know the role and frequency across different tumor types of HER2 aberrations. And globally speaking, we know that there are different types of aberrations. The most important ones: HER2 amplification, HER2 overexpression, and HER2 mutations. Important message here is that, as you see, both for stomach cancer, esophageal junction cancer, and biliary tract cancer, the proportion of patients that may have any of the aberrations is really important, especially for HER2 amplification and HER2 overexpression. So we will discuss a little bit how to deal the strategy on looking at the patients that have this kind of aberrations. And important also to look at the databases. And in this particular case, we have the shortcomings from a database in the United States, clearly showing that in the case of advanced biliary cancers, 81% of the patients were not confident in the ability for the use of different targeted agents in this particular tumor. Also, we do know from these registries that 85% of the patients receive first-line chemotherapy based on gemcitabine and cisplatin. 46% of the patients actually have the opportunity to receive second-line therapy, and only 17% of them actually can move to the third-line treatment. Important to mention that with the knowledge that we know right now of new targeted agents directed to specific aberrations, we should take in consideration to formally test all patients. And this is another database showing coming from more than 3,000 patients with advanced metastatic gastric or gastroesophageal junction cancer, again showing that 1/3 of the patients were not tested for HER2 status, and also only 58% of the patients that were disclosed to be HER2 positive actually receive HER2-directed therapies in the first-line setting. Moreover, we don't know that in second line, mainly patients receive chemotherapy, and sometimes because of the delay of looking for specific aberrations, actually there is no consideration to have opportunities with targeted agents. Important to mention also coming from these databases, and this comes from the Dutch Pathology Registry. Fortunately, in this setting in Holland, we have seen an increasing um, proportion of patients that have evaluation of HER2 testing over the years since 2010, now in 2016. But still, mentioning also about this database, only 77% of the HER2 patients with GI cancers actually receive trastuzumab. Finally, before moving to the first part of the presentation, we know that there are several mechanisms of activity in compounds targeting HER2. Initially, those that were considered single epitope monoclonal antibodies, like trastuzumab, the original one, like margetuximab and pertuzumab, more recently. Also, we have ADCs, antibody drug conjugates, targeting the ectodomain of the receptor, like trastuzumab endoncin and trastuzumab deruxtecan. Also by specific antibodies like zanidatamab. And finally, kinase inhibitors, small molecules with the capacity to inhibit the endodomain of the receptor, like lapatinib, neratinib, and tucatinib. So, without anything more, I would like now to give the podium to Professor Shubham Pant to cover the field of biliary tract cancer. Thank you.
Well, thank you, Dr. Tabanero, for that excellent introduction. I'm Shubham Pant. I'm a professor in the Department of GI Medical Oncology and Investigational Cancer Therapeutics at the University of Texas MD Anderson Cancer Center in Houston, Texas. Biliary tract cancers roughly can be divided into multiple little subsets. So, as you can see, there's gallbladder cancer, there's intrahepatic cholangiocarcinoma, and extrahepatic cholangiocarcinoma. And why this matters is because genomically they're very different tumors. For example, intrahepatic cholangiocarcinoma can have FGFR2 fusions, whereas gallbladder cancers and extrahepatic cholangiocarcinoma can have more HER2 amplification, especially gallbladder cancer, in which it can be HER2 amplified in 20 to 30% of patients. And precision oncology has really taken off in biliary tract cancers and has been the key to optimal management in advanced cancers over the last decade. And as you can see about these approvals, we had the FGFR fusions, starting with infigratinib, pemigatinib, futibatinib, most recently ivosidenib for IDH1 mutations, and most recently zanidatamab for breakthrough therapy designation for HER2 amplified cholangiocarcinoma. Now, the way to detect HER2 amplification in tumor samples, we can either do immunohistochemistry. So, when we are looking at just HER2 2 plus or 3 plus patients, which are considered positive, or you can do fluorescent in situ hybridization or next generation sequencing, in which you can find an over amplification of HER2. Now, just to give you an idea of the second line overall subset in patients with biliary tract cancers, this was a study of FOLFOX chemotherapy versus Bex supportive care, and the response rate in these patients was 5% in the second line setting in biliary tract cancers. Now, HER2 overexpression can have a prognostic endpoint in biliary tract cancers, just like breast cancer. In this study, resected patients with biliary tract cancers, when if they were HER2 amplified, they had a poorer disease-free survival and overall survival than patients with HER2 negative disease. These graphs are very similar to what we saw in the initial studies in breast cancer. Now, targeting HER2 past biliary tract cancers, it is a rarer disease. So we've looked at most of the data comes from basket trial. This was the first one, my pathway trial of pertuzumab and trastuzumab in HER2 positive metastatic BTC. And these patients received a median of 1 to 3 prior regimens of therapy. The overall response rate in these patients was 29%, with a progression free survival of 4 months and an overall survival of 10.9 months. And on account of this study, which was published in the Lancet Oncology, this is in the NCCN guidelines in the United States for HER2 positive tumors, BTCs, in which this was approved in the guidelines. in the NCCN guidelines. Now, moving on to antibody drug conjugates, the HERB trial was done in T-DXd in patients again with HER2 expressing unresectable or recurrent BTC. This was an investigator-initiated study in Japan, 5 trial sites. There were 30 patients, and majority of the patients, 11, were gallbladder cancer. The response rate was 36.4% in these patients, with a duration of response of 7.4 months. However, antibody drug conjugates can have side effects, including anemia, neutrophil count decrease, and white count cell decrease. You can also, in a small percentage of patients, get interstitial lung disease or pneumonitis, but that has to be recognized early to intervene in these patients. And we recently saw data emerging from ESMO 2023 for HER2 positive BTC. And this was a study called Destiny Pan Tumor O2, multiple tumors HER2 overexpressing. Overall response rate of 37.1%. For IHC 2 plus was 27.2%. For IHC 3 plus was much higher at 61.3%. If you specifically look at the biliary tract cancers, for all patients of BTC was 22%, the overall response rate. That's the one in purple that you can see on the graph. And for HER2 3 plus was 56.3%. Again, part of a basket trial. This study was presented in ASCO in 2023, which was tucatinib, a small molecule with trastuzumab, and there were 30 patients on this analysis. The confirmed overall response rate was 46.7%, with the median duration of response of 6 months. One of the main side effects of the combination was diarrhea. And now we come to zanidatamab, or ZW25. That is a bispecific antibody for HER2 expressing cancers. It binds to 2 unique domains on HER2, the ECD, or extracellular domain 2, and extracellular domain 4. And this binding can lead to enhanced receptor clustering on the cell surface compared to trastuzumab and pertuzumab, and inhibition of cellular proliferation, leading to ADCCs and other mechanisms. Zanidatamab was first evaluated as a basket within a basket trial in patients with locally advanced or metastatic HER2 expressing cancers. There was a dose escalation part of the trial, followed by a dose expansion. 22 patients of biliary tract cancers came in this analysis. And this is the anti-tumor activity in these patients with biliary tract cancers. The overall response rate in these patients was 38%, with the median duration of response. That means the patients who were responding, how long did they stay on the trial? The median duration of response was 8.5 months, with a median progression-free survival of 3.5 months. Again, this was a heavily pretreated population. And this led to this global phase 2b study of zanidatamab monotherapy in HER2 amplified BTC. And there were patients, again, with HER2 amplified, which was defined as in situ hybridization positive, that's ISH positive, with HER2 2 plus or 3 plus. There were also patients with 0 and 1 plus initially who were part of the trial. However, 7 patients were enrolled in this trial, and they did not show any new safety signal or responses. So what was reported in ASCO 2023 was on the 80 patients which were ISH positive and HER2 2 plus and 3 plus positive. Zanidatamab was given IV once every 2 weeks, with the primary endpoint of overall response rate and key secondary endpoints of duration of response, disease control rate, progression-free survival, and overall survival. It was a truly global trial in multiple countries across 32 sites in multiple continents. This was enrolled over approximately 2 years. This was the response rate. The response rates was looked at by independent central review and by investigator assessment. The confirmed overall response rate for patients was 41.3%, with a disease control rate of 68.8%. And this is the swimmer's plot. In this, you can see individual patients who were responding on the trial. The median duration of response for the patients was 12.9 months, with a median time to first response a relatively short 1.8 months. The progression free survival in this cohort was 5.5 months. The overall survival data is not yet mature and it will be reported out soon. The adverse events of special interest were captured, which was infusion related reaction. So, 33.3% of patients got any grade of infusion related reactions. However, patients did get they did get some pre-medications after a first few patients, and then we saw less percentage of infusion-related reactions. And this was mostly in the first few infusions, and then it improved. The main other side effects was diarrhea, but this was easily managed with some over-the-counter anti-diarrheal medicines and hydration. This is an updated data from ESMO 2023, the quality of life outcomes with zanidatamab. What this slide essentially shows is that the patients who got zanidatamab in the trial and they had a response, their health related quality of life did tend to improve in these patients. The conclusions and take-home messages from Horizon BTC-01 was that zanidatamab demonstrated antitumor activity, including rapid and durable responses in patients with refractory HER2-positive BTC. Zanidatamab had a demonstrated manageable and tolerable safety profile. Few events led to treatment discontinuation. There were no grade 4 AEs and no deaths were treatment related. Most common AEs, as we showed, were infusion related reactions and diarrhea, predominantly low grade and reversible. Coming to kind of some other combination trials, this was a TAB study, which was a poster in ASCO 2023, in which frontline patients were screened for HER2 status, and 90 patients were enrolled in this single arm trial, which was gemcitabine and cisplatin combined with trastuzumab in the frontline setting of HER2 positive BTC. Majority of these patients, more than 90%, were gallbladder cancer. The 6-month overall survival was 81.1% in these patients, with the 6-month progression-free survival of 75.6%. So an interesting signal in this disease in the frontline setting. This was recently also published, which is a combination trial of FOLFOX with trastuzumab for HER2 positive BTC, which was refractory to gemcitabine and cisplatin. 34 patients were enrolled with an overall response rate of 29.4%, median progression-free survival of 5.1 months. And these patients, though, did have side effects, with about 68% having some kind of grade 3 toxicity, either with the chemotherapy or with the combination. So now we come to a discussion of HER2 positive metastatic intrahepatic cholangiocarcinoma. We are here to discuss Brian, a 60-year-old man who has recently been diagnosed with multifocal intrahepatic cholangiocarcinoma with bilobar hepatic disease and metastases to the lung. ECOG of 1. Patient initiated gemcitabine cisplatin with durvalumab, and subsequently patient progresses. So, Dr. Tabanero, I'm going to tap you on this. What do you think the next step of management of this patient could be?
Well, thank you very much, first of all, Professor Pan, for raising this the case. I think that the data actually supports that this patient received as the first line treatment the combination of gemcitabine plus cisplatin and durvalumab. But of course, as you clearly pointed out, patients with biliary tract cancer actually have multiple or have the opportunity to have multiple genomic aberrations that lead to selected treatments for them. So I think that it's going to be important to have, a multi targeted test that could allow us to know any potential genomic aberrations. We can discuss a lot whether this has to be an NGS-based test or multiple PCR tests, but I think that for the best management of this patient, we need to expand the molecular profiling.
Yeah, so I think, thank you for that. I think What is heartening here is how the HER2 story carries on. How we started, more than about 1985 when it was first described, and then the antibodies came out, and how it kind of goes on in which in different formulations now these bispecific agents have come out, which can really provide some durable benefit for these patients. Uh, so the next step in management, Dr. Tabanero, you can click ahead if you want.
So, as anticipated, an NGS testing looking for multiple aberrations was done, and actually a HER2 amplification was found. So, how you will move forward in this setting?
Yes, that's great. So the ones, we have the NCCN guidelines in which we have the combination of trastuzumab and pertuzumab. That can be an option. Obviously, always we recommend patients go on a clinical trial. If a trial is available with zanidatamab, that's an option too. The counseling on the potential AEs, if they go on an ADC, that counseling is different. What I tell my patients, it is like a chemotherapy. It's, though it's a targeted agent, you can definitely see the side effects, fatigue, heme toxicities that you can see. And then with other things like zanidatamab, yes, you could get diarrhea. That is manageable, and some of the infusion related reactions we talked about, majority which were grade 1 and 2. But the great thing is there are a lot of different options for our patients in this setting. Thank you for the question, Dr. Tapanero.
Thank you very much. So now we can move forward to the next part of this session with updating the data that we have on potential role of HER2 targeting strategies in gastroesophageal adenocarcinoma. And of course, as we anticipated at the beginning, we need to have a clear stepwise process for uh, doing the best workup for our patients, including HER2 testing. So let's start with a case. Thomas was recently diagnosed with a stage 4 gastroesophageal junction adenocarcinoma with metastasis in the lungs. We ordered HER2 testing on the biopsy, and the pathologist came to us saying that the patient had HER2 overexpression, but with a score of 2 plus. So, in this situation, per the recommendations of almost all the guidelines, it's well recommended that patients should have a test for amplification. Initially, it was FISH. Moreover, right now it's more recommended TISH, because actually this defines a population of patients with IHC score 2 that may benefit more from the treatment with a HER2-directed therapy. This is what we did in our patient, and at the end, the patient had ISH 2 positive, so it was considered, as HER positive. An important thing here, actually, that relates to the assessment of HER2 status, especially in gastric cancer, that it's quite differential to breast cancer, is the importance of looking at a defined number of samples, between 5 and 6 at minimum. And we know that this is important because the heterogeneity of HER2 expression is well established in patients with gastric or gastroesophageal junction cancer. And the proportion of patients that may be HER2 positive, if we evaluate less than 6 biopsies, decrease, and we may exclude the patient from a potential benefit with therapy of HER2 directed agent. And actually, all the guidelines right now recommend that all patients with gastric, metastatic gastric, or gastroesophageal junction cancer should be considered for HER2 testing at diagnosis. And even more, NCCN guidelines have also included that the test should be considered at radiological progression or clinical progression of the disease, what actually it's going to become probably more standard of care in this setting. So once we have the results of this patient, as mentioned, IS positive, of course, we have to discuss with the patient which are the different opportunities that we have for them. And actually, we are going to make a review of these potential opportunities that were based on data published some years ago, but also on the more recent presentations that we have had, including the ESMO 2023 Pentis presentations. Important to mention that the seminal breakthrough paper presentation came from the results of the TOGA analysis that for the first time evaluated the role of combining trastuzumab in combination with the standard chemotherapy in the first-line treatment of patients that were HER2 positive. The overall survival data show an impressive benefit favoring the combination of trastuzumab plus chemotherapy, with a hazard ratio of all included patients that were HER2 positive of 0.74. And actually, this was considered the main standard and recommended in all guidelines. Nevertheless, post-hoc analysis looking at the potential subgroups that could define characteristics of patients that did benefit more from the treatment, including the level of HER2 expression, actually show that those patients that have IHC 3 plus or IHC 2 plus FISH or ISH positive are the ones that benefit more from the treatment. And actually, this has been considered in most of the guidelines and even in the regulatory approvals for treating patients with advanced metastatic gastric or gastroesophageal junction cancer with HER2 overexpression. With these excellent results of the TOGA study, other trials were conducted in the first-line setting and the second-line setting, trying to define whether other HER2-directed options could also benefit patients with this disease. Unfortunately, the phase 3 trials evaluating the role of pertuzumab on top of chemotherapy plus trastuzumab failed to show an advantage, a statistically significant advantage in overall survival, as well as trials evaluating the role of the HER2 kinase inhibitor lapatinib. A little bit similar succeed in the second line setting, where trials evaluating lapatinib or an ADC, trastuzumab, enhancing T-DXd, unfortunately failed to show any significant benefit in terms of overall survival. So this was the standard, the basis of treating patients with HER2 positive metastatic gastric or gastroesophageal junction cancer. Other trials have evaluated other compounds in this setting, and it's important to mention the data from the Keynote 811 study. And this trial, very simple trial, evaluated in this population of patients HER2 advanced gastric or gastroesophageal junction cancer, the addition of the immune checkpoint PD-1 inhibitor pembrolizumab to conventional trastuzumab and chemotherapy regimens in the first-line setting. This was a randomized study with different analyses, and actually in the interim analysis that was conducted almost 2 years ago, subgroup secondary endpoint actually looked for overall response rate, independently reviewed, and we were all impressed to see that those patients that received pembrolizumab on top of trastuzumab and chemotherapy achieved an overall response rate of almost 75%, but actually compared very well to the response rate in the control arm being 52%. More interestingly, in this year's ESMO meeting, the data of progression-free survival and overall survival was presented, and as expected, those patients receiving pembrolizumab on top of trastuzumab and chemotherapy had superior median progression-free survival with a hazard ratio of 0.72. This was for the all-comers population, but even more for the PD-L1 positive population. Actually, this hazard ratio went down to 0.70, showing again the benefit of adding pembrolizumab to the conventional treatment with trastuzumab and chemotherapy in the first-line setting. Moreover, we have seen other compounds that have been evaluated in this setting. One that I want to keep an attention also is trastuzumab deruxtecan. This is an antibody-drug conjugate of trastuzumab plus as a payload a topoisomerase inhibitor, deruxtecan. Naturally, this compound has multiple advantages. First, the ratio of trastuzumab payload molecules is very high, 8 molecules per of the payload per each molecule of trastuzumab, and also clear activity in preclinical models and in the clinical setting of bystander effect. So the data of trastuzumab deruxtecan in the advanced gastric and gastroesophageal junction cancer field. First data came from the randomized phase 2 study, the T-DXd 01, where patients that had previously received chemotherapy plus trastuzumab and had progressed to another line of therapy. So this was a third line or beyond setting, actually were randomized to receive trastuzumab deruxtecan as a single agent, or what physicians consider the choice therapy for the patient, either irinotecan or paclitaxel. And as you can see in the initial presentations, those patients that received trastuzumab deruxtecan had superior overall survival, increasing from 9 months to 12.5 months for favoring trastuzumab deruxtecan with a hazard ratio of 4.60. Also, a high magnitude effect in the progression-free survival figures with a hazard ratio of 4.47, and even more in the overall response rate. As you can see in the control arm, patients had an overall response rate of 14%, whereas in the experimental arm with trastuzumab deruxtecan, the response increased up to 51%. This study, the Gastric 01, was conducted only in patients from Asia Pacific, so it was important for the regulatory authorities to have data on Western country patients, and this was the case for the Destiny Gastric 02 study. This is a phase 2 single-arm study in the same population of patients in the same line setting, with the additional fact that all these patients needed a confirmation of the HER2 status before being included in the trial, and the primary endpoint, because this was a confirmatory study, was confirmed overall response rate. And as you can see here, the response rate is very similar to the one that was achieved in the Gastric 01 study. In this particular case, confirmed overall response rate 42%, and the 12 months overall survival rate 50.6%. So really an impressive efficacy data. You can see here the figures for progression-free survival on the right side and median overall survival on the left side, clearly showing the effect in the third line setting or beyond of these patients with metastatic gastric or gastroesophageal junction cancer being treated with trastuzumab deruxtecan. And thanks to these studies, actually, trastuzumab deruxtecan had the regulatory approval, first of all in Japan, later on in the United States, and finally in Europe. In the third line or later line in Japan, and second line or later line in the case of the United States and Europe. Although some other confirmatory studies are being conducted at this time point that will clearly define the best role for trastuzumab deruxtecan in this setting. Important to mention that trastuzumab deruxtecan has specific side effects on top of those related to trastuzumab. Probably the most important one, although not the most frequent one, is ILD. And actually, right now, there are very important rules to suspect and to manage ILD when it's present. Of course, when we have either symptoms or exhibition by any CT scan that the patient may have ILD, we have to confirm that potential diagnosis with multiple tests that are mandated in a stepwise process, as you can see here in this slide. And at the end, we have to manage ILD when it is confirmed. Very briefly, when we have grade 1, we have to put on hold the treatment until it resolves to grade 0, and we can consider corticosteroids in particular conditions. We can actually reintroduce the treatment if the toxicity has recovered to grade 0. But in case that we have grades 2 to 4 toxicity, it's recommended to permanently discontinue the treatment and probably initiate therapy with corticosteroids, essentially. Important to mention the other compound that also Professor Pant has mentioned before, zanidatamab, this paratropic HER2 targeted bispecific antibody. And in here, also for the gastric and gastroesophageal cancer junction cancer population. Actually, we had initial data coming from studies that, even in the phase 1 studies, with multiple tumor types overexpressing HER2. Actually, you can see in the right part that patients also with gastroesophageal cancer had amazing responses in this analysis. And this has been the basis actually to develop this open label two-part phase 2 study, CWY 201. Actually, this is a study for patients with unresectable, advanced metastatic gastric or gastroesophageal junction cancer without prior HER2 targeted regimens to receive three to receive the treatment in 3 different arms: zanidatamab in combination with K-POTS, zanidatamab in combination with 5-fluorouracil platin, and finally zanidatamab in combination with modified FOLFOX seeds or in the different schedules that have been developed. The primary endpoint of this study was to assess overall response rate. So what we can see, is that the treatment was very active in with all the different schedules. Perhaps the safety profile was a little bit different, but with the different chemotherapy backbones, although the numbers are very low to make definitive conclusions. Perhaps to point that diarrhea was the major toxicity that was found in this clinical trial, but it could be managed with prophylactic antidiarrheal regimens. Moving to the activity that I briefly alluded before, you can see here that including all patients that were included in the 3 cohorts of the study, the confirmed overall response rate was 75%, with disease control rate also almost 90%, but actually it's really very meaningful in this particular setting. This is the data for progression-free survival and overall survival, again showing in this first-line setting a very encouraging progression-free survival, median progression-free survival of 12.5 months, and the median overall survival when this was reported was not reached. Also, the zanidatamab data suggested to move forward in a formal phase 3 study, and this is the so-called Edison GEA 01 study for patients with advanced metastatic gastric gastroesophageal junction without prior HER2 targeted agents or immune checkpoint inhibitors, nor neither systemic therapy. This is a global study, a large study that aims to include a total of more than 700 patients, and patients will receive the control arm, trastuzumab. Still, in many patients, this is considered the control arm with conventional chemotherapy, or 2 experimental arms, one with zanidatamab combined with the conventional chemotherapy, and the second experimental arm combining zanidatamab with one PD-1, PD-L1 inhibitor, tislelizumab, combined also with conventional chemotherapy schedules. The primary endpoint for this particular study is progression-free survival by independent review, but also another co-primary endpoint being overall survival. There are other novel anti-HER2 therapies I'm going to be briefly mentioning in this slide. One of them is evorpacept. This is an anti-CD47 antibody. The very preliminary data of the randomized phase 2 ASPEN-06 study, combining in the experimental arm trastuzumab, ramucirumab, paclitaxel, and evorpacept in this second-line setting, has been press release, but we need the final presentations in a scientific format, but the results are very encouraging. The same for the kinase inhibitor tucatinib, that it's approved in breast cancer and colorectal cancer in patients bearing HER2 mutations. And actually, the phase 2 Mountaineer 02 study has fully enrolled patients with gastric and gastroesophageal junction cancer. Also, we have data or an ongoing study on sinrebafusp alpha. This is a a bispecific antibody targeting HER2 and 4-1BB, as well as other bispecific antibodies targeting HER2 and CD3 with intention of trafficking T cells into the tumor. Also, new HER2-directed ADCs are being evaluated, as well as HER2 cellular therapies. So, in summary, from the initial data of the TOGA study that consolidated the combination of trastuzumab chemotherapy as the first-line standard of care treatment for HER2-positive metastatic gastric cancer, we have seen the evolution that has been recently presented with many clinical trials, especially with pembrolizumab, that has been already approved by the FDA based on the response data from the Keynote A11 study, and now with the expansion of progression-free survival data very recently presented. Also, the ADC trastuzumab deruxtecan has been shown to has demonstrated to show advantage in overall survival in this refractory setting, third line or beyond, and even second line or beyond. And of course, one of the important aspects of this trial is to mitigate as much as possible the risk of ILD that these missed patients may have. Finally, other studies with trastuzumab deruxtecan are evaluating also the role of this compound combined with immune checkpoint inhibitors. Finally, concerning zanidatamab, the biparatropic HER2 antibody, the phase 3 Edison GA01 study is evaluating the role of this compound in combination with chemotherapy, and also in combination with chemotherapy plus an immune checkpoint inhibitors. And now, just to recapitulate what we have seen in this presentation, we're going to go with another case of a patient, 70-year-old male, that presented with symptoms related to the primary tumor, even with a weight loss. And actually, the workup revealed a gastroesophageal junction cancer that was HER2 positive, IHC 3 plus, proficient for mid-match repair, and PD-L1 CPS 10. Actually, we found that this patient had a test revealing LV2 amplification, and the complete workup actually showed that the patient had extension into the liver and also into lymph nodes. So the question here first is how we would manage this patient, and which would be the recommendations for systemic treatment. I don't know whether Dr. Pan wants to make any comment on this.
Thank you, Dr. Tabanero. I think this patient would have multiple different options. As we've seen, it could be the first line with the trastuzumab with the checkpoint inhibitor. That could definitely be an option. A clinical trial targeting like the bispecific antibodies that we talked about, like zanidatamab, or the ADCs like T-DXd could be an option for these patients at this time. And even if they progress on front line, let's say with the trastuzumab, I think second line they have certain options, especially with the ADCs. So I think just like the BTC, we've shown again a wide variety of a number of options could be available for these patients, targeted therapy options for these patients with gastroesophageal adenocarcinoma.
Thank you for your comments, Subham. Actually, this patient, because of the data of the Keynote study, was treated with a combination of pembrolizumab, trastuzumab, and FOLFOX. Actually, the patient improved very rapidly from the symptoms that he had. The CT scan showed very rapidly a response, and of course, oxaliplatin was discontinued with the usual recommendations after 8 cycles for grade 1 neuropathy. And the patient could continue after these 4 months of therapy with an additional 4 months with pembrolizumab, trastuzumab, and 5-fluorouracil-leucovorin. At that time point, actually, the patient presented progression of the disease, both by increasing of the clinical symptoms, but also progression in one of the liver metastases. So, Dr. Pan, which would be your next step in this setting?
I feel like I gave it away with the previous slide, but I think clinical trial or we could consider an ADC, just like T-DXd in the second line setting. Obviously, like you've said about the pulmonary toxicity, we need to watch out for that. Rare, but can really have significant side effects for the patient.
Thank you, Professor Pan. Well, one of the things that I mentioned before, and is being mandated more and more, especially for the regulatory labels of trastuzumab deruxtecan, but other compounds may be the case, is to repeat biopsy, right? So just showing that the patient continues to have expression or overexpression of HER2 positive disease. And actually, this was the case in this patient. And again, as you mentioned in here, we had the discussion of whether this patient should be treated with paclitaxel, ramucirumab. That was the standard of care treating these patients in the second line setting in an all-comers fashion. But also right now we have other options like trastuzumab deruxtecan that has been shown to be active in this even second line setting, although the regulatory labels do not consider that in all places in the world. But as you mentioned, also the data that we have on sanidatamab, if there was a trial um, allowing for these patients, I think that it should be really a very good option in this setting. With this, we come to the end of this session. First of all, I would like to thank all of you for being here with us, evaluating all these new insights in the field of biliary tract cancer and gastric and gastroesophageal junction cancer, especially for the HER2-related expressing population. Of course, I would like to thank Professor Subhan Pan for his excellent presentation and interaction. And finally, also to thank our PeerView colleagues for helping us to do this session. Thank you very much again.
Thank you so much, Dr. Tabanero.
This activity is certified by PVI, PeerView Institute for Medical Education. Remember to download the slides.